I have the pleasure to introduce our last speaker of today, Dr. Vincent van Tittelboom. Just finished his EACTAIC Fellowship at our center, the OLV Clinic. And during his talk, he will demonstrate with a few cases how intraoperative use of the EEG can be a valuable tool to manage patients intraoperatively during cardiac surgery. Vincent, the floor is yours.
Dear colleagues, it is now a little over a month that I finalized my EACTAIC Fellowship in cardiac thoracic and vascular anesthesia in the OLV Clinic in Aalst and started working in the AZ Moderators Hospital in Ghent. And I must say it was an absolute pleasure and a privilege that I was given the chance to give this talk about the use of processed EEG during cardiac surgery, which is a subject I got familiar with during my fellowship last year. First of all, I would like to say that I have no disclosures to report for this presentation. Now, next to standard ASA monitoring, invasive monitoring is a universally accepted component of perioperative care in cardiac surgery patients. However, we have far less information about brain function during general anesthesia when compared to the monitoring of other vital organs. This is sobering, considering that the brain is the most vital organ in our patients, and it's also our main target when administering general anesthesia. Therefore, it is no surprise that recent recommendations promote the use of brain monitoring to individually titrate anesthetic drug administration and to protect and preserve brain function in our patients. As cardiac anesthesiologists, we know that titration of our anesthetic drugs is crucial, as our patients are mostly older and more fragile. Also known is that cardiopulmonary bypass profoundly affects the way our drugs are distributed and cleared by the patient's body, and also changes how our drugs interact with the patient's receptors to produce their effects. Due to these profound changes in pharmacokinetics and pharmacodynamics, it is easy to understand that these factors may also affect the depth of anesthesia. Using processed EEG monitoring, we may visualize episodes of burst suppression during the course of cardiopulmonary bypass. Burst suppression is seen more often in the older, frail patients and far less in the young patients undergoing cardiac surgery. Now, these episodes of burst suppression usually reflects a level of anesthesia which is too deep, although other factors should always be considered as well. For example, metabolic impairments may also lead to burst suppression, and this should of course be addressed at once. The importance of detecting burst suppression lies in its association with postoperative cognitive dysfunction and delirium. The incidence of postoperative cognitive dysfunction, for example, is about 5 times lower when burst suppression can be avoided during surgery. And not only the number of episodes of burst suppression is important, but also their duration. As shown in this slide's table, the incidence of delirium is directly proportional to the duration of burst suppression during surgery, and its incidence increases dramatically when the duration exceeds 10 to 15 minutes. As already addressed by the previous speaker, a processed EEG can monitor and help us guide the anesthetic depth of a patient. Especially helpful for this is the use of the spectrogram, which is provided on some of these monitors, which transforms the raw EEG signals into a clear color-coded frequency pattern. For those of you that are not fully familiar with the spectrogram, I would like to share some slides which summarize its main concepts. The color code of the spectrogram ranges from blue, which indicates the loss of activity, to yellow and red, which indicates high levels of activity. An example of this color coding can be seen in this slide, which shows a spectrogram of a brain during anesthesia. During anesthesia, the most active frequencies are situated in the alpha and the slow wave delta regions. The higher awake frequencies are colored in blue, indicating they are turned off. On this slide, different spectrograms are shown. On the top right, you see the spectrogram of a young patient, while on the left, the spectrogram of an older patient is shown.